Chapter 13, 10 questions to ask when planning a curriculum. Planning and implementing a curriculum requires careful attention. To detail, 10 questions provide a useful checklist. The 10 questions. Curriculum development is a serious business that requires careful consideration and planning. In this chapter, we highlight 10 questions that need to be addressed. 1. What is the medical school or training program's vision or mission? 2. What are the expected learning outcomes? 3. What content should be included? 4. How should the content be organized? 5. What educational strategies should be adopted? 6. What teaching methods should be used? 7. How should assessment be carried out? 8. How should details of the curriculum be communicated? 9. What educational environment or climate should be fostered? 10. How should the process be managed? What is the medical school or training program's vision or mission? What sort of doctor does the school aim to produce? If the school was a car factory, would its program be designed to produce economy cars, family saloons, luxury limousines, sports cars, or off-the-road four-wheel drives? Is it the future teacher or academic, the research worker or the doctor who is able to work with the local community? Perhaps all of them. In Australia, Canada, Scotland, and other countries, there is a need for doctors to work in rural areas. Is there sufficient emphasis given in medical school to prepare doctors to practice in rural communities? To what extent do students' cultural and ethnic backgrounds mirror the population they have to serve after graduation? Are medical schools responding to the challenges presented by globalization and international dimensions of medical practice? Schools need to recognize that there is now a greater mobility in the medical workforce, and doctors need to have the necessary skills to function effectively in whatever part of the world they are working. In a consideration of the vision for a medical school, a question needs to be asked about the social accountability of the school. Over the last decade, the concept of social accountability of medical schools has gained momentum. As defined by WHO, social accountability places the obligation of medical schools to direct their education, research, and service activities towards addressing the priority health needs of the community, region, and or nation they have a mandate to serve. Social accountability is recognized in the Aspire to Excellence initiative, where international excellence in medical education in a school is recognized and the criteria for social accountability are specified. Marrying a curriculum with the school's vision is often ignored or taken for granted. There is merit in taking a step back and considering how this vision impacts on the design of the curriculum in terms of the learning outcomes, the approach to teaching, learning, and assessment, and the educational environment created. What are the expected learning outcomes? Key to a curriculum are the learning outcomes. We highlighted in section 2 the importance of learning outcomes and the move away from an emphasis on the education process to an outcome-based education model where the emphasis is on the product. We looked at how learning outcomes can be described as they relate to technical competencies and clinical skills, approaches to practice embracing an understanding of the basic sciences, appropriate attitudes and decision-making strategies, and personal development and professionalism. Decisions about the learning outcomes should inform the answers to the questions that follow. What content should be included? With the rapid expansion of medical and scientific knowledge and the development of new specialties, information overload is now a major problem facing medical education. While the content has expanded significantly, the time available in the curriculum has remained relatively constant. Attempts to shoehorn more and more information into the time available with an already overloaded curriculum are self-defeating. More content can lead to less learning. Decisions need to be taken regarding what to include in the core curriculum and what to omit. There has been considerable debate, for example, about the coverage of anatomy and other basic sciences in the undergraduate curriculum, and whether the level of detail could be curtailed without jeopardizing the student's understanding of the subjects as related to the practice of medicine. Decisions about what to include at each stage of training must be taken in light of the agreed learning outcomes and, as described in Chapter 12, the need for authenticity in the curriculum. There is a core content which has to be mastered by all students. Opportunities to study subjects in more depth through electives or student-selected courses should also be provided as described in Chapter 20. Also discussed is the idea of threshold concepts, difficult concepts that are essential for the student to master. Doctors can now readily access information through the internet and other sources when they require it. In the past, the situation was very different. The emphasis was on knowing everything and believing that you knew everything. The core content curriculum must provide students with the vocabulary, understanding, and skills necessary to identify and interpret information gained online and elsewhere. How should the content be organized? With the learning outcomes and the content determined, the next step is to consider how the curriculum should be organized and the content sequenced. The traditional approach in medical education has been to introduce students first to the basic medical sciences and normal function, structure, and behavior of the human body. As students progressed through the curriculum to the later years, the focus was on abnormal function and the development of clinical skills. Later, students developed their clinical competence on the job as they managed patients. This sequence, while having much to commend it, has major disadvantages. In the early years, with a focus on the basic sciences, the relevance of the content was not obvious to the student, and as we discussed in Chapter 3, the learning may be less effective. There are alternative ways of sequencing the content that lead to more effective and efficient learning as students progress through their training. This is important and is covered in Chapter 14. What educational strategies should be adopted? The educational strategy adopted may be seen as the key element in a curriculum, with the curriculum even labeled in terms of the dominant educational strategy. For example, a problem-based curriculum or a community-based school. The SPICES model for curriculum planning identifies 6 educational approaches and presents each on a continuum. The most appropriate point on each continuum is likely to be somewhere between the 2 core points. An assessment by staff and students of the school's position on each dimension may be a useful step in planning a curriculum. The SPICES model can be used also for curriculum evaluation with the current position on the continua compared with the desired or optimum position for the school. Figure 13.1 The SPICES model of educational strategies. As student-centered, teacher-centered, pre-presentation based, information-oriented, I integrated or interprofessional, discipline-based. C. Community-based, hospital-based. E. Elective-driven, uniform. S. Systematic, opportunistic. Student-centered, teacher-centered. There has been a significant move towards a more student-centered approach in the curriculum, as described in Chapter 15, with students given more responsibility for their own learning. It is what students learn that matters and not what teachers teach. Teachers are also being challenged and programs scrutinized to establish whether they are meeting the needs of individual students in terms of content, approaches to learning, and time taken to complete. Presentation-based, information-oriented. A problem-based approach to learning has been adopted by a number of schools over the past 2 decades. The starting off point and the focus for the learning is a clinical problem. It is what the students need to know to understand the problem that drives the activities. The curriculum can be structured around the problems with which patients present. This is discussed further in Chapter 16, Integrated Discipline Based. There has been a significant move away from curricula based on courses that relate to individual subjects or disciplines such as anatomy, surgery, and pathology, to courses integrated around the body systems, such as the cardiovascular system. There is also a move towards a significantly greater integration between the basic medical sciences and clinical subjects. An interprofessional approach where different professions share to a greater or lesser extent their learning experiences is being explored and implemented in some education programs. This makes sense given the need for students to develop teamwork skills. Integration and interprofessional education is explored further in chapters 17 and 18. Community-based, hospital-based. There has been a move away from a curriculum that provides only a hospital-based setting for students to gain their experience. More attractive is a curriculum that offers, in addition, experience in a community setting. This is covered in Chapter 19. In the past, there has been a mismatch between the students' experience in the hospital setting where they receive the majority of their training and their experience in community settings where most patients receive their health care. Elective uniform. A curriculum should include both core elements common to all students and electives or student-selected components. By designing a curriculum in this way, there are advantages for students who can study topics of their choice, as described in Chapter 20. Systematic apprenticeship. In a systematic approach to a curriculum, there is a clear statement of the learning outcomes, and the teaching, learning, and assessment is planned and related to the outcomes. This is in contrast to an opportunistic apprenticeship model where lecturers address whatever topic is of interest to them and students' experiences in a clinical attachment depend on the patients they see as they present during the attachment. What teaching methods should be used? After decisions have been taken about the expected learning outcomes and the educational strategies to be adopted, consideration should be given to the teaching methods used. The last decade has seen a re-examination of traditional teaching methods such as the lecture with a greater emphasis on small group work and independent learning, on the use of new learning technologies including simulation and e-learning, and on learning in different clinical contexts. Attention has also been paid to care-assisted learning, where students are formally involved in the education of their peers or more junior students. The teacher's toolkit. A competent carpenter or joiner has a toolkit with a range of tools, each of which has a key function for which it has been designed. A hammer is used to insert nails. Pliers could be used for the task, but they are less efficient. The toolkit will include several types of saws, each suited to their own task. With chai, the carpenter will replace old tools with new improved versions that incorporate the latest technology. If we employ a carpenter, we will expect him to have a comprehensive toolkit with the appropriate tools to tackle the job for which he has been engaged. Replace carpenter with teacher, and the situation should be no different. The teacher should have a comprehensive, up-to-date range of tools for teaching and learning. Students or trainees have the right to expect that we will incorporate in our teaching the methods most appropriate for the stated learning outcomes. In Section 4, we highlight the key tools in the teacher's toolkit, including new approaches such as the flipped classroom. Much of a student's education today takes place away from the lecture theater and the tutorial room. Today's students are very different from those of previous generations, and they learn at home and informally from each other. Networking and collaborative learning play an important part in their studies. How should assessment be carried out? A key element in the curriculum and one that significantly influences students' behavior is assessment. It is essential, as shown in rubrics or blueprints, that assessment matches closely the expected learning outcomes. Decisions have to be taken about the overall assessment strategy and the appropriate instruments to be adopted with this in mind. The objective structured clinical examination and assessment portfolios were introduced to meet the need for more authentic and performance-based assessment instruments. Work-based assessment has grown in popularity, particularly in postgraduate education. Attention has also been paid to a closer integration of assessment and learning with the associated concept of assessment for learning as well as assessment of learning. Section 5 describes established and newer approaches to assessment and the key issues that have to be addressed when an assessment program is planned. This includes setting appropriate standards. How should details of the curriculum be communicated? With the increased sophistication of the undergraduate and postgraduate curriculum and the use of strategies such as problem-based learning and integration, students and trainees require assistance with understanding what is expected of them, the learning opportunities available, how they can make best use of the learning opportunities, their progress through the curriculum. Teachers and trainers too may have difficulty in grasping their role in the process and in appreciating what is expected of their students in the phase of the program for which they have a responsibility. If the curriculum is to succeed, teachers and students need to know what is expected of them. There is a need for a curriculum document that includes a clear statement and explanation of the expected learning outcomes, a series of blueprints relating the learning outcomes to the available learning opportunities, the phases of the curriculum and the assessment, a curriculum map as described in Chapter 22 that shows the relationship between the different elements in the curriculum, what educational environment or climate should be fostered. Important but often ignored in the consideration of the curriculum is the educational climate or environment. This represents the overall atmosphere students experience wherever learning takes place. It embraces, for example, the extent to which students feel they are studying in a supportive or threatening environment and whether the environment encourages teamwork and collaboration, appropriate professional behavior, and creativity. A number of instruments are available that allow the educational environment to be measured. This topic is discussed in Chapter 21. How should the process be managed? It should be obvious by now that the development and management of a curriculum is an important and demanding activity that requires careful planning and allocation of time and resources. Most medical schools and postgraduate bodies have recognized this and have set up committees charged with responsibility for the curriculum. A curriculum planning committee should represent all stakeholders. Both hospital and community-based interests should be represented, and junior and senior staff and students should be included. Individual members of staff should be allocated responsibility for implementing the different aspects of the program, including the coordination of each phase in the curriculum, the organization and delivery of each course, the management of electives and options, student assessment, support for students, including students with difficulties, computer and information technology, a clinical skills center, and the use of simulators and simulated patients. It is important that staff who contribute to the education program are recognized and rewarded for their efforts by promotion on the basis of their contribution to teaching and the scholarship of education. Educational programs that are most successful have strong leadership from deans or clinical directors with support given by them for changes and innovations in the curriculum.